Hi there, welcome back. It's Dr. Suchard, and the topic today is cyanide and antidotal therapy for cyanide poisoning. The objectives for this topic are that when you're finished with the video and studying any related course materials, you should be able to identify at least 3 sources of cyanide exposure, describe the clinical signs, symptoms, and laboratory findings seen with cyanide, explain its mechanism of toxicity, and to name and explain the mechanisms of action of 2 antidotes for cyanide poisoning. The word cyanide is derived from the Greek root kyanos, which means dark blue, and this Greek root word was chosen because of Prussian blue. Prussian blue had been a popular pigment since the early 18th century. For instance, we can see its use here in the Great Wave off Kanagawa. In the early 19th century, the chemical composition of Prussian blue was found to include iron cations and Cn- anions. Cn- was called cyanide, literally meaning blue ion, because it came from this blue pigment. Now look to the upper right. By convention, in chemistry, we represent carbon atoms as black and nitrogen atoms as blue, but the choice of blue here is more likely related to the sky being blue and our atmosphere being comprised mostly of nitrogen than anything else. And how is it that people can become exposed to cyanide? Cyanide is used in multiple industries, including the manufacture of paper, textiles, and plastics. The Cn- ion forms soluble salts with many metal cations, so it's used extensively in mining, electroplating, and metallurgy. And because it is a metabolic poison, cyanide can be used in fumigation, although safer agents are more commonly used today. In fact, you may have heard of Zyklon B, a cyanide-containing agent that was used in the Nazi death camps in World War II. It was initially created before the war for commercial purposes as a fumigant and marketed like a cyclone that would rid your house of bugs. A more common mechanism of exposure to cyanide comes from smoke inhalation. Cyanide is produced when nitrogen-containing materials burn, such as in building fires. Much of the fuel for fires is carbon-based, and it gets oxidized mostly into CO2, carbon dioxide, with smaller amounts of CO, carbon monoxide. But when nitrogen, as found in synthetic materials like plastics and foam and in wool, burns, the nitrogen combines with carbon, releasing cyanide. Although we often think about carbon monoxide poisoning in people exposed to fire and smoke, it is quite possible to have combined CO plus CN poisoning, which may have some impact on how sicker smoke inhalation victims are treated, as we'll see later on. There are also several plant foods that contain cyanogenic glycosides. As these compounds are metabolized, they release cyanide, but our bodies are able to handle the small amounts we're typically exposed to. Amygdalin is a diglucoside with 2 glucose molecules that is found in several fruits, concentrated in the seeds or kernels. And we don't typically eat these seeds or kernels, although the risk is increased, say, with bitter almond varieties that contain more amygdalin compared to the now common sweet varieties. Linamarin, a monoglucoside, is found in lima beans and in the cassava plant, which is a staple food crop for many people living in the tropics. Cassava undergoes extensive processing, which eliminates the cyanide risks under normal conditions. But when these measures are skipped, as in times of famine, dietary cyanide poisoning can occur. Cyanide exposure can also occur from some drugs. Sodium nitroprusside is used to treat hypertensive emergencies as a continuous IV infusion in the ICU. In its chemical structure, we see that it can release a molecule of nitric oxide, NO, which provides the desired vasodilating effect. However, as it's metabolized, it can also release 5 cyanide ions. Cyanide toxicity can occur with high doses of sodium nitroprusside or prolonged infusions, especially if the patient has underlying renal insufficiency. Prusside, Prussian Blue, cyanide, see the connection? The other drug to mention here is Laetrile. Laetrile is not a drug you're going to learn about anywhere else because it's a quack cancer treatment. No reputable physician or pharmacist deals with Laetrile, but you can still find it being sold and used. Laetrile is a monoglucoside analog of amygdalin and is touted as a natural cancer killer that preferentially poisons the cancer cells with cyanide. That's a great idea, but it just isn't true. Laetrile is also called vitamin B17 to try to make it more appealing as a dietary supplement and/or natural cure. But again, there is no such vitamin, and this is just false advertising. Cyanide inhibits cytochrome C oxidase, also known as complex 4 in the mitochondrial electron transport chain. Here we see the electron transport chain in the mitochondrial inner membrane. As electrons from NADH and FADH2 flow down the chain, hydrogen ions are pumped from the matrix to the intermembrane space. This chemical gradient powers ATP synthesis. Cytochrome C picks up electrons and is reduced by complex 3, and then carries those electrons where it drops them off and is oxidized by complex 4. Thus, complex 4 is also called cytochrome C oxidase. If we inhibit the action of cytochrome C oxidase, the electron transport is halted, we stop pumping hydrogen ions, and ATP synthesis shuts down. There are a few poisons that work by inhibiting cytochrome C oxidase, including cyanide, azide, hydrogen sulfide, and carbon monoxide. This slide is a close-up of complex 4, where we see how the electrons, E- at the top, which were taken from cytochrome C, flow first to a copper atom, then to cytochrome A, where the red square represents its iron-containing heme group, then to cytochrome A3 with a light blue square as its heme group, then to another copper atom. And finally, the electrons are used to reduce oxygen into water. As all that is happening, hydrogen ions are pumped from the matrix into the intermembrane space, as shown in the curved green arrow. But if cytochrome A and A3 are inhibited by cyanide, this whole process shuts down, blocking oxygen utilization, and resulting in the same downstream biochemical and cellular effects as hypoxia, as not having enough oxygen in the first place. Next, we're going to watch 2 short animated clips demonstrating this mechanism in finer detail.
At the heart of this system are 4 protein complexes, numbered 1 through 4. Complexes 1, 3, and 4 directly pump protons from the matrix into the intermembrane space. Proton pumping requires energy, and the 4 protein complexes get this energy by transferring electrons through a series of coupled reactions. This linked process of electron transport is why the 4 complexes are collectively referred to as the electron transport chain. Cytochrome C carries the electron to complex 4. The electron transport chain ends in complex 4, where a series of reactions involving 4 electrons converts a molecule of oxygen to 2 molecules of water. The proton gradient is strengthened because 4 protons from the matrix are incorporated into water molecules, and another 4 are pumped into the intermembrane space. In the absence of oxygen, the electron transfer comes to a halt, meaning that ATP synthesis also stops. Indeed, the reason we breathe oxygen is so that it can serve as the final electron acceptor at the end of the electron transport chain.
A group of proteins on the mitochondrion's membrane form the electron transport chain. Carrier molecules donate electrons from food to the chain. As the electrons flow, the chain pumps protons out of the membrane. These protons move back across the membrane through the protein ATP synthase, causing it to spin and make the cell's energy source, ATP. When cyanide is ingested or inhaled, it inhibits the protein cytochrome C oxidase. This backs up the whole chain, and ATP production stops. Within minutes, cell death can occur.
Cyanide poisoning causes cellular hypoxia. Even if the patient is provided with adequate oxygen, the cells can't use it. This results in a shift from predominantly aerobic to anaerobic metabolism. Instead of glucose being metabolized to pyruvate, then to acetyl-CoA and fueling the Krebs cycle, the glucose goes to pyruvate and then to lactate. Lactate can accumulate, and we see an elevation in the serum anion gap. At the same time, the serum bicarbonate levels decrease, which is essentially the definition of a metabolic acidosis. Some sources make a big deal about skin color changes with cyanide poisoning, but this is not a frequent or a reliable sign, and we're discussing it here mostly to dispel the idea that it is important. The issue here is whether the skin will be red or blue. On the blue side, some people assume that cyanide will make people cyanotic. As we've already discussed, there's a definite link in the etymology of these words, but the blueness here relates to Prussian blue. On the red side, there's the issue that cyanide reduces oxygen consumption, resulting in higher partial pressures of oxygen in the blood, and therefore, now for the leap in logic, that the patient's skin should be redder than usual. This doesn't make sense. While it's true that skin color is affected by oxygen saturation, under non-poison conditions, that blood is normally close to 100% saturated, so increasing the PO2 a bit further can't cause any appreciable color change. You can, however, see arterialization of the veins, where the PO2 of venous blood is higher than normal. But since you'll probably be giving the patient plenty of oxygen, it would be hard to know if increased venous PO2 came from that or from cyanide. However, if you looked in the back of the patient's eyes, you might see that the retinal veins had a color more like retinal arteries, which would be pretty subtle and only noticed if you were skilled at that part of the physical exam already. Back on the blue side, though, it seems pretty reasonable that a cyanide-poisoned patient who rapidly lost consciousness and stopped breathing, or who had insufficient breathing, could become hypoxic through that mechanism, and that would make them cyanotic, just like anybody else who stopped breathing. Similarly, there are some sources that make a big deal about cyanide and cyanide-poisoned patients smelling like bitter almonds. Despite its popularity in books and movies, this is an unreliable, misunderstood, and not always present sign. It is true that amygdalin, the cyanogenic glycoside found in almonds, contains benzaldehyde, which has a sweet almond or cherry scent. There's benzaldehyde in real and in artificial almond flavorings. But that's the scent of sweet almonds rather than bitter almonds, which are so rare nowadays that hardly anybody knows what they smell like. Several sources also mention genetic variations where some people can't detect that smell anyway, or maybe it never smelled that way to begin with. Next, we're going to watch a 1.5-minute long clip where an amateur chemist tries to answer this question.
Please don't try recreating anything that you see here. Cyanide is probably one of the most well-known poisons, and in many movies and shows, I've heard them say that it smells like almonds. I've also heard chemists say it, and I've seen it written in a lot of articles and warnings. However, I've never actually smelled it myself, which is probably a good thing, but I've always wondered how true it was. So I decided that I had to see for myself. To make this happen, what I had to do was pretty simple, and I just had to smell some cyanide. Okay, so I have my scary little box here, and I guess I just have to smell it. Honestly, it's not as strong as I thought it would be, but it's not at all like an almond. I would not associate this at all with food. It really has a chemical smell. It kind of smells like weak bleach or chlorine. And maybe a little bit like an indoor pool that has too much chlorine in the air. Either way, it's not almonds. I don't smell anything that resembles almonds here.
Since cyanide interferes with oxygen usage, it causes the same signs and symptoms as hypoxia. On the milder side, you may see some non-specific things like headache, dizziness, and shortness of breath. But higher doses may cause loss of consciousness and cardiovascular collapse within seconds. This table mentions an elevated serum lactate. In the correct clinical setting, such as rapid onset altered mental status and vital signs changes, a severely elevated lactate should make you suspicious for cyanide or for poisoning by other mitochondrial metabolic poisons. While it is possible to order blood cyanide levels, the results will not come back in a time frame to be helpful in making clinical management decisions. Empiric treatment needs to be started before a laboratory-confirmed diagnosis can be made. Next, we're going to see a video demonstrating how potent and how fast cyanide can be.
A dramatic end to the life of a convicted war criminal. Just seconds after the United Nations Court upheld his 20-year sentence for war crimes, Slobodan Praljak refused to sit, instead proclaiming his innocence.
Slobodan Praljak is not a war criminal.
And then the retired Croatian army general pulled a small vial from his jacket, tipped his head back, and drank the liquid, telling the court it was poison.
Stop, please. Please sit down.
A short time later, an ambulance arrived, taking Praliak to a Dutch hospital where he died. The courtroom is now a crime scene, and the big question is, how did the convicted criminal manage to get that vial of poison into The Hague, where security is tight? The Dutch police are now investigating. Linda Kincaid, CNN.
There are two main antidotal treatment options for cyanide that we're going to discuss. The traditional Cyanide Antidote Kit contains a combination of nitrites and sodium thiosulfate. At the top here is an older generic Cyanide Antidote Kit, which you can see contains additional equipment beyond just the meds, such as syringes, needles, and a nasogastric tube, so you don't have to search for all of these components, wasting time when you're treating a cyanide patient. In the lower left is a brand name antidote kit, which only contains vials of meds. Another brand name kit is shown here on the right, which includes some equipment, sodium nitrite, sodium thiosulfate, and amyl nitrite pearls. Amyl nitrite is a volatile liquid which is packed into small spheres, which are crushed and release the drug as a vapor to be inhaled. Obviously, this only works if the patient is breathing. The rationale behind the nitrites, sodium nitrite or amyl nitrite, is that they oxidize the ferrous or +2 iron in hemoglobin to ferric +3 iron, forming methemoglobin. The ferric ion provides a cyanide sink, an alternate binding site for cyanide other than in the mitochondria. When methemoglobin binds to cyanide, this forms cyan methemoglobin, sometimes called cyanomethemoglobin. The cyan methemoglobin carries the cyanide to the liver, where the cyanide can be detoxified through action of the enzyme Rhodanese. We've already discussed that some plant foods contain small amounts of cyanide, so it should be no surprise that our bodies have mechanisms for detoxifying and eliminating it. With cyanide poisoning, these mechanisms have been overwhelmed, but we can augment them with the next drug in the Cyanide Antidote Kit. Rhodanese detoxifies the cyanide, Cn-, to thiocyanate, SCN-. The sodium thiosulfate we administer provides an exogenous sulfur donor, augmenting this normal detoxification mechanism. Thiocyanate is much less toxic than cyanide, and it is eliminated through the kidneys into the urine. Now you'll notice that the name of the enzyme Rhodanese seems to be spelled incorrectly, since enzyme names normally end with ASE. Rhodanese, however, was named before that convention was adopted, so it retains its atypical spelling. Now onto the dosing of meds in the Cyanide Antidote Kit. The amyl nitrite pearls for inhalation are only used in the pre-hospital setting and only if IV access is not yet obtained. This is the component of the kit that's hardest to keep in stock, since sniffing amyl nitrite can cause a euphoric head rush, so it mysteriously keeps going missing. IV sodium nitrate is preferred over amyl nitrite. Adults get 10 mL of a 3% solution for a total of 300 milligrams, given over a few minutes. You have to watch for hypotension since nitrites and nitrates can cause vasodilation. Pediatric dosing is, as typical, by weight, but there is also some dose dependence on the hemoglobin level. You give an amount proportional to the hemoglobin level to avoid causing too high a degree of methemoglobinemia. Dosing tables for this are available, although not shown here. Theoretically, there should be some hemoglobin dose dependence in adults too, but apparently everyone ignores that because there's more room for error. Sodium thiosulfate, 12.5 grams IV, is then given in adults, and the pediatric dosing is weight-based. The other cyanide antidote strategy is to use hydroxycobalamin. Hydroxycobalamin is a newer cyanide antidote that exchanges a hydroxyl group to instead bind a cyanide ion. Hydroxycobalamin is a very large molecule that is a provitamin. It is just one step away from becoming cyanocobalamin, vitamin B12. Since it is only a single drug, hydroxycobalamin is easier to administer than the traditional Cyanide Antidote Kit. But then, just to be confusing, the trade name for this drug is cyano-kit. There is a kit, but it just contains the drug vial and IV infusion equipment. The drug vial is very large because it has to hold gram amounts of the drug, since each molecule of this very large drug binds to only one cyanide ion. Hydroxycobalamin has a favorable side effects profile compared to nitrite-based antidotal therapy. It doesn't cause methemoglobinemia, which reduces the blood's oxygen carrying capacity. This may be a particular advantage in combined CO-CN poisoning from smoke inhalation. Hydroxycobalamin also does not cause hypotension like the nitrites can. In fact, patients actually briefly get hypertensive from hydroxycobalamin, probably because it scavenges endogenous nitric oxide. The most predictable and prominent side effect of hydroxycobalamin is that it causes temporary reddening of the skin and body fluids. As we've seen, the drug itself is deep red, and you have to give a lot of it. Pictured here is a volunteer subject in an early hydroxycobalamin study. On the left was the day she was given placebo, and on the right was the day she got hydroxycobalamin. This is seen too in cyanide poison patients. This woman's skin is bright red, and so is her urine. This discoloration is benign, but it can last for several days, and can interfere with several colorimetric lab tests, and make dialysis machines think there is a blood leak and shut themselves off. This last slide contains some visual mnemonics from Klaus and Bruce that you might find helpful regarding cyanide and cyanide antidotes, but I'll let you go over them on your own. And that's it about cyanide. I'll be seeing you around.